What are the key clinical signs that suggest this child has a mediastinal mass?
Positional symptoms: increased shortness of breath when lying flat, orthopnea, use of accessory muscles, and tachypnea. Suggest respiratory distress. Inspiratory stridor. Suggests airway compression. The chest X-ray and CT scan. Findings of a large mass with tracheal compression are consistent with a mediastinal mass. The child sleeps sitting up to prevent airway collapse.
What complications are associated with an anterior mediastinal mass?
Airway obstruction. The mass can compress the trachea, leading to partial or complete obstruction. Cardiovascular compromise. Compression of major vessels such as the superior vena cava can lead to superior vena cava syndrome or compromise the right ventricular outflow tract. Pericardial effusion. A significant effusion may cause cardiac tamponade, which is life-threatening. Difficulty with intubation. The mass may compress the trachea distal to the endotracheal tube, preventing effective ventilation even after intubation.
What are some high-risk features for respiratory or cardiovascular collapse in patients with a mediastinal mass?
Presence of respiratory symptoms, such as cough, orthopnea, or stridor. Compression of the trachea or main bronchus, as seen on imaging. Positional symptoms. Worsening symptoms in the supine position. Evidence of cardiovascular involvement, such as pericardial effusion or superior vena cava compression.
In a patient with a mediastinal mass, what is the most appropriate management if anesthesia is required?
Avoid deep sedation or general anesthesia, unless absolutely necessary. Keep the patient breathing spontaneously. If sedation is required, use agents like ketamine or dexmedetomidine to maintain spontaneous breathing. Avoid neuromuscular blockade, as this can cause airway collapse. Preload optimization. With 4 fluids before anesthesia to counteract vascular compression. Elevate the head of the bed to maintain lung volumes and prevent airway collapse in the supine position. Be prepared for emergency management with rigid bronchoscopy or extracorporeal life support if airway obstruction occurs.
What factors should be considered before administering empiric treatment corticosteroids to reduce the mass effect?
The need to balance diagnosis and staging. Steroids may shrink the mass, potentially impacting the diagnostic yield. For lymphoma, the severity of the mass effect on the airway or cardiovascular system. If life-threatening symptoms are present, early empiric treatment may be necessary. Potential alternatives for non-sedated diagnostic procedures, such as a biopsy under local anesthesia, or blood tests, which may avoid the need for sedation.
Why is spontaneous ventilation preferred over positive pressure ventilation in these cases?
Spontaneous ventilation allows the child to maintain their own airway tone and reduces the risk of airway collapse. PPV can increase airway compression by changing thoracic pressures, worsening the mass effect on the trachea and vascular structures. If PPV is necessary, it should be done gently and briefly to assess the child's tolerance. If tolerated poorly, immediate return to spontaneous breathing is preferred.
How would you manage acute airway obstruction in a child with a mediastinal mass?
Positioning. Elevate the head of the bed, or place the patient in a lateral or prone position to relieve compression. Emergency interventions. Prepare for rigid bronchoscopy to relieve airway obstruction. Consider extracorporeal life support. If other measures fail to stabilize the airway, preload the patient with 4 fluids and support adequate heart rate to ensure cardiovascular stability.